culture incubators you can actually put in clinical areas, and they take blood culture and directly put it into the machine there. And as soon as they put a new blood culture onto the machine on the ward, the central machine in the laboratory will notice that. So there is a constant vigilance on that particular blood culture as well. And that is all happening because there is a national standard that within 4 hours, the blood culture should go on the machine. And then there are other standards of the analytical phase. When blood culture signals positive, within 2 hours, gram stain should be done. If you're going to do any rapid antigen testing, that should be done within 2 hours of flagging positive. If you're going to do any direct identification, then that has to be done within 24 hours, and so on. And in the post-analytical phase, a negative result should go out at 48 hours. However, the NICE has given another criteria for neonates, which is 36 hours. So if the blood culture is negative at 36 hours after the collection, then it's unlikely to grow any organism after that. So the NICE standard says at that time, the laboratory should release the results so that clinicians can see it, because in neonates, blood cultures are done at a drop of a hat, basically. If the neonate is not suckling properly, looks, feeding is poor, or just crying excessively, these are the sometimes indications for doing blood cultures in neonates. Or CRP is, say, about 15, 20, so raised. They do septic screen. But at 36 hours, there is a second NICE standard which says you repeat CRP at 36 hours. And if 2 CRPs are normal, taken 36 hours apart, then you have excluded sepsis in that neonate. And what on the top of that clinician would want is a negative blood culture at 36 hours. Now, this is again only possible if you have automatic machine, and that gives you a negative result at 36 hours. A final result should be available within 5 days, which is fair. So this is all about blood culture stewardship. The diagnostic or laboratory stewardship example I want to give you is use of C-reactive protein, CRP. We know it is an acute phase protein. We know now it has been taken over by procalcitonin to a greater degree. However, in my hospital, we don't do procalcitonin. We know CRP and procalcitonin, they increase after inflammatory trigger. They are mainly useful in investigating patients who may have systemic bacterial or sometimes fungal infection. Fungal infection is questionable, but you do see some rise, unlike, say, viral infections. And occasionally, they are used for screening for monitoring of disease activity. So inflammatory conditions, so rheumatic, sometimes rheumatic patients, or connective tissue disorder, it's a rheumatic one, or malignancy patients, gastro patients, they do require CRP. So these are the common use of CRP. Now, a few years ago, we looked at our CRP use, and this is a number. This is what we found for those 12 months that we analyzed. More than 37,000 requests. Now we're talking about 250-bed hospital and 37,000 CRPs in a year. When we looked at the granularity, we found the A&E and hemato-oncology, they were the biggest culprit. The highest one was hemato-oncology, and then followed by hepatology and liver department. And there are other departments. When we looked into why hemato-oncology were the highest users, somehow in their protocol, it was written, do CRP every day on anyone who has neutropenic sepsis. Now, when you look at the literature, or when we ask the clinician, what is the use of CRP on a daily basis? If the patient has infection, they have infection. It is established, because you are not going to give antibiotic to a neutropenic sepsis patient just because CRP is raised. You are giving antibiotic because they have temperature. That is what neutropenic sepsis means. And once you start antibiotic, you are going to wait until the temperature settles down. Give 48 hours or so after that. You will want to make sure that their cell count has increased a little bit. So CRP doesn't play a major role here. Likewise, we discuss with A&E. And again, if the patient has, say, clear-cut viral infection like bronchiolitis, what's the point of doing CRP there? If the patient has, say, a good going simple joint infection, which you can clearly see that their joint is inflamed, again, maybe I think there might be case for doing one CRP at that time, but what's the use of doing CRP on a daily basis or even every other day for that matter? So a hospital-wide discussion ensued, and then we agreed certain criteria, and we agreed that in these cases, CRP is not necessary. So one, clinically obvious and uncomplicated viral infection. You don't need to do it. Your diagnosis is query measles here. Why do you want to do CRP there? Clinically obvious bacterial infection. So if somebody presents with, say, multiple abscesses, which is sort of staphylococcal or group A streptococci, CRP doesn't add anything to that. Or patient who had surgery or trauma in preceding 48 hours. So patient just had, say, a bad appendicectomy done. They are on antibiotics. There is no point doing CRP on that patient unless something is happening after 4 or 5 days where mild temperatures starts again, and you want to see whether there is an inflammatory response or not, whether this patient is brewing some infection somewhere. And if the differential diagnosis does not include any acute or chronic inflammatory condition, then there is no point doing CRP. And everyone agreed with that. So what we did was we took out CRP from the daily panel, because when people request on electronic systems, sometimes they have, say, hematology panel or ICU panel, and CRP was part of that. So every day, whether the patient needs it or not, CRP would be done. So we took that out, and what we said is, if you want to do CRP, then you have to specifically request, you have to click that, yes, I need CRP. On the top of that, we also added a 44-hour rule. 44, normally it should be 48 hours. So basically the principle was, we don't want clinicians to repeat CRP within 48 hours of the last one. But because people normally start work in the morning, and sometimes you want to repeat it after 2 days, but still 48 hours hasn't been completed, it might be irritating for them not being able to request CRP. So we put 44-hour rule base. So when you click the CRP request on a hospital system, it will tell you that the CRP has been done within the last 48 hours. If you really need CRP, pick up a phone and discuss with either biochemistry or microbiologist, or give a good clinical reason here. And the third thing we said, if the patient is clinically improving, then you don't necessarily need CRP just to prove that. Now, when we implemented that, within a month or 2 months, the CRP use drastically reduced by more than 30%. At that time, the cost of CRP was about £7 per test. And when we talk about 10,000 less, there was a huge savings for the hospital. This is again what we mean by right test for right patient at right time. It doesn't mean that you always have to do the test. Not doing test is also sometimes correct thing to do for patient as well as the healthcare system. Another test I want to talk about from diagnostic stewardship point of view, and what we do here, is about cerebrospinal fluid, CSF PCR. So here is a scenario. An 8-month-old presenting with fever, 38.5 degrees Celsius, not feeling well, and the CRP is 35. Blood culture and urine has been sent. Then they managed to do lumbar puncture. On the CSF examination, there is no increase in white cell count. The protein is within normal limit, and no organism is seen. However, the clinicians have requested CSF PCR. Now we use BioFire, the film array here. What do you do in this condition? Now, if this was a small one-to-one learning or small group, I would have asked this question to the audience and taken some opinion, but I'll just carry on here. Previously, we would just do it because it has been requested by a clinician. So there must be a good reason, we would think. As you know, BioFire CSF panel is a very useful, lovely panel. It has multiple bacteria and viruses that commonly present from community, and also a yeast cryptococcus as well. What we did was we said, look, we are going to look at, say, NICE guideline on sepsis and meningitis. That's the basis of our recommendation. And in our lab, we said, look, we are not going to test all CSF that comes to us asking for CSF PCR. There has to be a good reason to do CSF PCR. And for that, we use a combined laboratory and clinical-based criteria. So what are they? In any child who is less than 6 months of age, we do PCR whenever it is requested. And the reason was, when we audited our yield, which organisms we were seeing, we typically found that enterovirus infection in children, which sometimes may present as sepsis actually rather than meningitis, that may present with normal CSF values in very young children, so less than 6 months old. Now, this was nothing new in literature that has been described for long. So we said all less than 6 months old, wherever CSF PCR is requested, we will do that. But all CSF from non-neurosurgical patients with abnormal white cell count or protein level is tested by film array PCR. So our lab has been empowered. So I don't have to do anything. My laboratory technician, when they do CSF count, they check, okay, is this neurosurgery patient or not? Because neurosurgery patient, they have CSF sent for a variety of reasons, including infection, but the film array panel is not useful for neurosurgical patients anyway, because organisms like coagulase negative staphylococci, propionibacterium, other gram negatives like Klebsiella, Pseudomonas, they are not part of the panel. So there is no point doing that. The panel is good for community acquired type infections. But then the lab will look at, okay, abnormal white blood cell or protein, they will automatically do CSF PCR. Now, any other request for CSF PCR where the CSF is normal, or it is, say, there is a clotted blood there, so the lab cannot decide whether there is high blood cell count or not, even protein becomes unreliable. So those cases would come to me as a microbiologist, and they will ask me whether this requires PCR or not. And I would find out from hospital system, either electronically or from the patient's clinical team, what was going on, and then ask them to do it. Now, one test here in UK costs £150. And by not doing almost, I would say, third of our CSF by using this criteria, we are saving quite a lot of money. The next example I want to give you is viral PCR. Again, we use BioFire, but look at this case, a 4-year-old with a runny nose, difficulty in breathing, and diffuse infiltrate on both lungs, presents to our ED, and then gets admitted. Rightly, they want to know which virus is causing this one. Now, previously, so before COVID era, during the bronchiolitis season here, which is sort of December, January month, around Christmas time, anyone presenting with clinical bronchiolitis, we would not test them because they have bronchiolitis. There's no point proving that, because clinicians can clearly tell you that this patient has bronchiolitis. Now, if the patient had, say, underlying chronic lung disease, etc., yes, we would do that. Or if we suspect influenza, when there is a lot of influenza out in community, we would do BioFire. But in this patient, so a BioFire was done, and it was positive for respiratory syncytial virus and rhinovirus. Both are known to cause bronchiolitis type illness, but this child is a 4-year-old, so they can't have bronchiolitis. Bronchiolitis is for very young patient. Normally, it's less than 1-year-old, less than 2-year-old, but not in 4-year-old. The patient was isolated in a single room, as it would be required for RSV and rhinovirus patient. And the previous speaker said quite a lot about source isolation. So this is an example here. And after 4 days, patient improved drastically, which is the normal course. But then clinician used to ask for a repeat swab because they wanted to check, whether the organism has gone or not. And when you ask the reason, they say, yeah, we want to tell the patient, but also if it's negative, then we can then de-isolate patient from this room to a single room, like sort of evidence of eradication. Now, as you know, film array has plenty of organisms. There are about 17, 18 organisms, a variety of viruses, and nowadays also the COVID is also part of the panel. And some useful bacteria, very useful, I would say, mycoplasma and pertussis. We isolate mycoplasma and not isolate, but we identify mycoplasma and pertussis often using film array. But normally our day-to-day work is all around influenza, para-influenza, and coronaviruses. And we said that was not a useful way to use or cost-effective way to use film array. And we agreed criteria with clinicians and said, look, we are not going to do for every patient that you ask for, but let's agree that any complex patient with previous comorbidities, we will do this PCR, not repeat PCR, talking about the first time PCR. Any patient who is on pediatric intensive care unit or who requires some sort of oxygen support, we would do the test. We would do the test for any hospital onset respiratory illness because we want to know if somebody acquired, if the infection is healthcare associated. We do see time to time hospital acquired rhinovirus infections, for example. This could be from other patients, but also patients' own family members who are visiting the patient. But we reject any request where the clinical information is not sufficient. Now, previous speaker again spoke about not having clinical information. In UK, we can easily say no, that we are not going to process the blood culture, even blood culture or any PCR if there is no clinical information. And everyone agrees, clinicians agrees as well, because it's very important for the lab to know what's wrong with the patient, for us to decide which is the best test, and to start with whether the test is appropriate or not. So if it is uncomplicated UTI, if it says, say, cough for last 2 days, you don't get viral PCR. If it says bronchiolitis, then unless they have underlying condition, we wouldn't do that. If they ask for evidence of eradication because they want to de-isolate, we would say no, because now with COVID, everyone knows a dead organism could be sitting there for days. In case of rhinovirus, in fact, we have found it to be positive 3 months after original infection. Again, when sometimes they ask to guide antibiotic use, because they say, yeah, patient has lower respiratory tract infection, but if you show that it is a virus, then we wouldn't treat. And we say, no, that's not a good enough reason to do this test, because even if I say it's rhinovirus or respiratory syncytial virus or parainfluenza virus, that doesn't tell you that the lower respiratory tract infection in this patient is not caused by superinfection like a bacteria. For that, you have to look at other parameters like whether CRP is raised or not, whether the patient's is productive, patient has productive cough or not, etc. You should not be relying on this test result or viral test panel for deciding on antibiotic use, because antibiotics are for bacteria, and a risk assessment whether a superbacterial infection has occurred or not is completely separate issue. And to guide infection control. Now, nowadays, I think that has changed a bit because we need to exclude COVID. And sometimes when you have a complex patient and we want to exclude COVID and other viruses, we would say, okay, even for infection control purpose, we would test them. But in general, this is what the criteria we normally use. Again, this is another example of right test for right patient. The another example I want to give for diagnostic stewardship is vancomycin therapeutic drug monitoring. Now, when you put patient on vancomycin or teicoplanin, ideally one should be doing pre-dose level. And the reason being, these antibiotics act in a time-dependent manner. What it means is you require good amount of vancomycin throughout the period of between the doses. So area under the concentration curve, so that is your amount of antibiotic divided by the minimum inhibitory concentration of the organism. That's the best predictor. So when you use AUC upon MIC, that basically tells you that this antibiotic is likely to act in a time-dependent manner. What it means is if you put somebody on vancomycin, say 2 times or 3 times a day, then almost on a daily basis, ideally you should be doing the antibiotic levels. Once a good state is achieved, then you can do twice a week or so, depending on the renal function, etc. But what it means is quite a lot of fiddling. When the nurses will have to spend so much time. So if you put patient on 3 or 4 times of vancomycin in pediatrics, just to clarify, in adult setup, normally you can get away with twice daily vancomycin. In a younger children, they clear vancomycin very, very quickly. So you have to use sometimes 3 times, 4 times a day vancomycin regime. And even then you sometimes fail to achieve good levels that you require. So for good going coagulase negative or Staphylococcus aureus infection, you require more than 10, but normally we would say more than 15 is ideal, milligram per liter of vancomycin. But to avoid all those complications, we introduce vancomycin continuous infusion, which is very practical. It is cheaper because less nursing time is spent. There is much less variability in the level that we achieve, and the levels are very, very easy to monitor as well. So this is another example of, it's not just what you do in the laboratory, but as a microbiologist, you help the wards achieve stewardship in a various in a various way as well. But also, giving a good dose of vancomycin is important if you want to stop development of heteroresistance or vancomycin intermediate or vancomycin resistant organisms. A good level of vancomycin is important, and continuous infusion actually helps you there. Another example is urine culture reporting. Now, this is a minefield, as you know. Urine is one of the commonest specimen that a microbiology lab normally receive. And there are so many variabilities in terms of, whether what is significant bacteriuria. Okay, if it is significant, but if there are no white cells, what are you going to do? Or there are full white cells, but the bacterial count is little less. Is this significant, not significant? And there are so many permutation combinations that work. I'm going to use here only a few of them. Ideally, every lab should have a proper chart for the laboratory technical staff to help them to report urines. And then finally, the clinical microbiologist should check every positive result, at least, if not negative, to make sure that they make sense to the clinician. Also, the other thing is we don't release all antibiotics that are there on the system, on the card. Like, you have 5 cephalosporins or 3 or 4 quinolones. In UK, you don't do that. You just give them 1 cephalosporin, which you want them to use, like cefalexin or cefuroxime or ciprofloxacin, no levofloxacin, moxifloxacin sort of stuff as well. I mean, clinicians here don't know what levofloxacin is, basically. And moxifloxacin, forget about it. Nobody has ever heard about moxifloxacin. Okay, so with urine, you require a robust SOP. As I said, a table. Pyuria is more than 10 white cells per mm cube. But does that mean if somebody has, say, 15 white cells, that they have urinary infection? Probably not. In our experience, there are 3 categories. One is less than 10. Then there is a good number of patients between 10 to 100 white blood cell per mm cube. And then third is more than 100. And we would consider if it's more than 100, then yes, there is likely a good going UTI here. Between 10 and 100, we would say it's neither here or not there. You got to look at the patient symptoms, look at the organism grown, and then make a judgment whether this is really UTI or not. Many laboratories, less than 10 white cells on microscopy or on autoanalyzer, they are not cultured at all. You just don't culture them. You don't just discard those urines. There are some exceptions there, which we'll discuss in the next slide. Then, what is the definition of significant bacteriuria? Well, more than 10 to the power of 4 organisms per ml is what significant bacteriuria means. But does that mean if somebody has, say, organism between 10 to the power of 4 and 5, then that is infection? Well, we don't know. But what we know is if it's more than 10 to the power of 5 CFU, that is colony forming unit or organisms per ml, then that is more likely to represent infection. So what we do is, if the cell count is less than, say, 100, if the organisms are between 10 to the power of 4 and 10 to the power of 5, so, not sure whether this is infection or not, we release the organism, release the cell count, but don't release antibiotics. We suppress them all. And we put a comment. So what we report is if pyuria, if more than 100, then we'll say pyuria present. If colony count is more than 10 to the power of 4, we report. If more than 10 to the power of 4 and pure growth and with pyuria, we report. Now, exceptions are immunocompromised patients, transplant patients, because their cell count may be obviously low because of underlying immunosuppression, or complex urology patients because they will have mitrophenol, artificial urethra, bladder washout, and so on, or suprapubic catheter urine. In those cases, we would report whatever we've grown. But in other cases, we would use the criteria above. Now, we suppress antibiotics if the cell count is not more than 100. We suppress antibiotics if the growth is less than 10 to the power of 5. We suppress antibiotics if there is uncommon organism grown, which is sort of not known routine organism that you normally find. And what we say is, this is one of the few comments that we put. We say, repeat urine to confirm the diagnosis, treat only if symptomatic. And most importantly, we say antibiotic susceptibility testing results available on request to the lab. So if you think this patient still requires antibiotic because clinically they have infection, you have to pick up a phone, discuss with clinical microbiologist, convince them why do you think this patient requires antibiotic, and then microbiologist will say, okay, this is a particular antibiotic you should use out of this sensitivity testing. So that again is another example of stewardship, because when you send the result out, see, the principle of pathology lab is this. As a clinician, what one need to think is, if I'm going to send the result, send a test request, do I know what am I going to do with the result? Right? Do I know how to interpret? If I don't know that, then do I know somebody who can help me interpret that? So there is no point sending a test request if you don't know what you're going to do with the test, or you're going to do what you're going to do anyway, irrespective of what the result was. Another example of diagnostic stewardship is transplant viral monitoring. Now, as you would know, post-bone marrow transplant and solid organ transplant patients, they are at increased risk of their own viruses, like, say, CMV, EBV. They come back because those viruses, once in your body, they remain in your body forever, waiting for immune systems to go down. When immune system goes down, they start to replicate and can manifest as clinical disease. So CMV, EBV, and adenovirus, those three are the most important ones. But in some cases, you do see BK virus infection. In our bone marrow transplant, we sometimes see, but importantly in kidney transplant, BK virus is an important one. Now, there are various strategies people use. One strategy is to use prophylaxis for particular virus. So ganciclovir, for example, for prophylaxis of CMV is commonly used. If you don't want to use prophylaxis, then the second strategy is monitor. And what you do is do bloods every often until, say, first 100 days after the transplant, because that's the highest risk period. And when you start to see even a low level of viruses, just count over 60 or 100, whatever your low level of detection of the PCR is, then you start preemptive treatment. So you start treatment, but that treatment is called preemptive because the patient is not unwell, but the test is positive. So to avoid them developing proper disease, you use preemptive treatment. Now, if you are prophylaxing, then there is no need to do viral, that particular viral monitoring. So that has to be agreed with your clinical team. But once you agree that, okay, let's do viral monitoring, then normally all international guidelines, etc., would say once a week is sufficient. And if the organism becomes positive, so CMV or EBV is positive, then you have to increase the frequency for that particular organism only to twice a week rather than all of them. Now, again, previously, the hemato-oncology junior doctors twice a week would send on blood on everyone because, rather than trying to find out who is positive, who is not positive, they are new to the ward, and senior says, look, twice a week, send blood to the laboratory and they'll do the PCRs. We said, no, that's not happening. You have to justify why you want to do it. So any request before 1 week, that is rejected. Any request, they might request all 3 viruses, but the lab would check what is their positive for previously. If they're positive for EBV, they get only EBV. If they are positive for adenovirus, only adenovirus, if the request is within less than 7 days. One test basically costs £30 in our setup here. So just think about, number of specimens sometimes we reject and how much money is basically saved for the system. Another example I want to give is gastroenteritis. Now, let me just check the time that I'm not overrunning. Doesn't look like. I'll carry on anyway. Is gastroenteritis. Now, here is a case, a child with 48-hour history of diarrhea, abdominal pain, and blood in stool who is attending emergency department, right? So that's your one patient, patient number 1. Patient number 2, a child with global developmental delay. They have chronic lung disease. So this typically you see in premature babies, and then they grow into children on a 2, 3, 4, 5-year-old, but they sometimes have chronic lung disease, endocrinal issues, and global developmental delay as a result of prematurity. Now, this patient has been admitted to the hospital more than 2 weeks ago. And now, in hospital, they have developed 2 episodes of diarrhea and feeling nauseous. So the question is the organism, spectrum of organism likely to be same in this both presentation? My view is no. The first patient is coming from community. They have different kind of exposure. The second child is in hospital. Now, depending on your hospital and the normal hygiene you have, there is a different etiology. What it means is the first patient could have Salmonella, Shigella, Campylobacter, amoebic dysentery, and other things, normally unlikely to be viral when you have blood in stool. While the second child who is in hospital, unless the hospital hygiene is very, very poor, you're not going to see Salmonella, Shigella, and Campylobacter in those who are admitted to hospital. But definitely what you see is viral gastroenteritis from one patient to another one. If there is another patient with rotavirus, another patient with norovirus is admitted on the unit, then this person, the next patient can get that. So the UK standard microbial investigation, they normally endorse what is called 72-hour rule. What it means is, if the sample received in the lab is from a patient who has been less than 72 hours from admission, so either in ED or they develop diarrhea within first 72 hours, then you are required to check for community organisms plus another risk organism. So routine culture, and that would be Salmonella, Shigella, Campylobacter, E. coli, O157. You test for C. diff if the risk is present. So if it says previous antibiotics or immunocompromised, then we would check for Clostridium difficile. And also if there is a transplant patient who's coming from community, then you need to think about CMV, adenovirus, because those two, the GI manifestation of them could present as gastroenteritis. But also rare organisms like sarcovirus and astrovirus, which is very uncommon. But you need to think about that. But those who are post 72 hours in hospital, as I say, unless the hygiene is extremely poor, you are not going to see Salmonella, Shigella, Campylobacter, and E. coli. So you got to do local risk assessment and say, you can check your last 10 years data just to see how many of these organisms you isolate in patients who are more than 72 hours in hospital. And based on that, you might say, look, we are not going to waste our resources in culturing for these organisms because it just doesn't make sense. You want to concentrate on rather organisms which are important, like norovirus. And if norovirus is negative, noro is very common, that's why it comes to my mind. But sapovirus and astrovirus, uncommon, but nevertheless, they are available on the film array panel. So this is what happens in many UK laboratories. Less than 72 hours, culture for everything. More than 72 hours, no routine culture. Another example is Clostridium difficile testing. Now, it's important to distinguish colonization of C. diff versus the Clostridium difficile infection. Not every diarrhea in a patient who has GDH positive or a PCR positive is Clostridium difficile. That we have to remember, because Clostridium difficile colonization is little more common than we normally think. In children less than 2-year-old, some papers suggest up to 20%, depending on which test they normally use, could be positive with C. diff colonization. So in UK, less than 2-year-old, they are routinely not tested for C. diff. In less than 2-year-old, the clinician will have to ring the lab to the microbiologist, discuss why they think this patient could have C. diff, and only if agreed, then C. diff testing is done. Otherwise, routinely it is not done. For more than 2-year-old, those who are on antibiotics or immunocompromised, or those whose stool meets the requirement, so it basically takes the shape of the container, so it's liquid, proper liquid, then the first test we normally do is a GDH antigen, because it's very cheap. But also, sometimes we end up with PCR, because when we do GI PCR on a selected patient, Clostridium difficile is also there. So that's how we sometimes pick up PCR. But Cafade also has a C. diff PCR on its own available as well. Now, if any of this positive, GDH or PCR, what that tells you is that there is a presence of this organism. That doesn't mean the patient, the organism is producing toxin and making the patient unwell. So the next stage is always to prove that the organism is producing toxin. So when GDH or PCR result is positive, then that is not tested for toxin testing. And if the toxin testing is positive, only then a person is labeled as Clostridium difficile infection and put on treatment. Now, there is always going to be an exception where the toxin may be false negative. But this is where, again, clinical microbiology comes in. Every GDH or PCR positive case is reviewed by microbiologists by going on the ward, trying to see what their drug chart shows, what their output chart shows, how severe the diarrhea is, whether they are explained by their underlying condition or not. Because patient could be on formula feed, which can give you diarrhea when the feed is changed. If patient is immunocompromised, I mean, if you look at, say, neutropenic patients, they typically would have very loose stool. And if you pick up a C. diff positive on that one, that doesn't necessarily mean that they have C. diff infection. So, and then if we think that this patient could have C. diff, I would then get to the hematology, oncology, or whoever the consultant is, discuss with them, and then we agree what treatment to give. Another example is sputum culture. Growing gram-negative organisms like Klebsiella, Serratia, Enterobacter, or Candida is common in hospitalized patients because they are exposed to multiple antibiotics, and hence you grow this sort of organisms. The peak organism that the previous speaker said, that's an example of that. But this does not always correlate to lower respiratory tract infection. So what we do is, when we isolate these gram-negatives, or Candida, well, we don't do Candida susceptibility anyway, but we don't typically test. First of all, the lab will not test for sensitivities on a regular basis. I'll come to that, how frequently we do testing for antibiotic susceptibility. But typically, this susceptibility testing would be suppressed, so clinicians cannot see it. If they think that this patient has low respiratory infection with a bacteria, or this grown bacteria could be significant, in that case, they have to discuss with clinical microbiologists and agree that, yes, this does sound like infection and this is the antibiotic. you would use. Repeat testing I was talking about, again, from diagnostic stewardship or laboratory stewardship point of view, is very important, because you have chronic patients, you have long-term patients, you have ventilated patients, you have patients on tracheostomy, where they will have sputum or tracheal secretion sent to you twice a week, thrice a week, and so on, because either it looks thick or sometimes for monitoring. And there are patients like, say, burns patient, who after a few days, many of them, not all, I think the rate here in UK is very, very low. I remember my surgical days in India, and every burns patient at that time would grow Pseudomonas invariably, while I was amazed to see here in UK, Pseudomonas infection in our burns patient is actually rare. And that is all down to good infection control. There is no magic here, that the magic is in hands and the environment cleaning. So these patients, what do you do when you isolate organisms repeatedly? Do you do sensitivities on all the time? We've got to be aware that, yes, there might be some merit in knowing the sensitivity, because when you put patient on antibiotics, then there are some organisms that can become resistant while being on treatment. So, for example, take Pseudomonas. Pseudomonas, when you try to treat with beta-lactam antibiotics, initially they may respond, but after, say, 2 weeks of treatment, so some patients have, say, super deep infection with Pseudomonas, then the porine mechanism kicks in, and the organism would suddenly become resistant to meropenem if you're treating with meropenem, or it produces starts producing beta-lactamase in a greater amount, and will become tazocine, for example, and so on. So that working knowledge is very important. Or the organisms like AMSP producers, like, say, Enterobacter. When you try to treat those organisms with cephalosporins, like cefotaxime or ceftriaxone, then the MC gene becomes de-repressed, and the organism starts to produce beta-lactamases, which then would make the antibiotic ineffective. That working knowledge is important. But in general, if an antibiotic susceptibility done one day, then normally it should not be repeated until a period of time. So, for example, our cystic fibrosis patients who are normally colonized with or get colonized over a period of time with Pseudomonas aeruginosa, and they remain colonized for their whole life, unfortunately. But then they send sputum sample every twice a week or so, when they do, every time they do physiotherapy. Yes, you will isolate Pseudomonas, but do you have to do susceptibility every time? No. In case of our cystic fibrosis patient, we have agreed that we'll do susceptibility every 3 months, because the susceptibility result, first of all, does not correlate with clinical outcome. However, you want to give antibiotics to which the bug looks sensitive, but in cystic fibrosis, it is may look resistant to, say, tazocine, tobramycin, so aminoglycoside, etc. But high dose tazocine, high dose tobramycin, that combination is commonly given, and patient become well as well in a relative term. While the sputum type things, we would say it's the lab will have to ask the microbiologist, is second antibiotic susceptibility required or not required? And depending on how well I know the patient, I would normally say no if I don't know the patient, and only if I had a phone call saying, look, this patient's condition is a little bit deteriorating and I have advised next level of antibiotics, then I would say, yeah, do the sensitivities, because I need to now know. So this is how we conserve our resources. I think that is it from me. So thank you very much. And I'm happy to take any questions you might have. Hello, can you all hear me?
Thank you so much, sir. I think there are no questions, but we would really like to extend a heartful gratitude from the entire team of AIMS Patna for taking time from your busy schedule and enlightening us today.
Lovely. Thank you very much. It was my pleasure to be here with you. Thank you, Pratusha. Thank you, Dr. Thakuria.
Good evening, everyone. It is my great pleasure now to introduce a name synonymous with the medical education across undergraduation and post-graduation in the field of microbiology, Dr. Apurva Shankar Sastry. He is Infection Control Officer in charge, Antimicrobial Stewardship Lead, and Additional Professor Microbiology, JIPMER, Pondicherry. He is popular figure among students, authored 9 books and contributed to several chapters in hospital infection control for NCDC. Dr. Sastry has 65 scientific publications and has been the investigator of various multicentric projects. I welcome you, sir, for the concluding one for SPCon 2021 on diagnostic stewardship.
So the chart. So which screen you want to share?
Good afternoon, everyone. Lot of lethargy in the crowd. I was told that tea break has been postponed. I can't hear. I can't see anybody's eyes having interest to the session. Eyes, not hands. Okay, so the whole day we have heard about a lot about diagnostic stewardship. I mean, every speaker have spoken at least something about the topic already before my session starts. So by this time, we all know the AID model of antimicrobial stewardship. AID model stands for the 3 components. They are like 3 different compartment of antibiotic stewardship. Any one compartment doesn't work, the whole system fails. So it is something like the care bundle approach. Like one of the component fails, then the whole system of stewardship fails. So my particular session is pertaining to diagnostic stewardship. So again, it is been told by the previous speakers that diagnostic stewardship is nothing but the clinicians should be capable of the right test. The clinicians should be capable of ordering the right test. So in order to order the right test, they have to do the correct infective syndrome diagnosis. So the most important part of diagnostic stewardship lies in the hand of the clinicians, because they have to correctly identify the infective syndrome and they have to put on the right test to the microbiologist, followed by right specimen. Right specimen, again, this is another component of diagnostic stewardship which lies in the hand of clinicians, not the microbiologists. They should know how to collect the sample appropriately and how to transport the sample within the required time period. Like let's say, for example, most of the culture AST investigation, we need a transport time of less than 2 hours. This is what is the requirement and the recommendation. So the first two components, of course, lies in the hand of clinicians. Then comes the role of microbiologists, where they have to perform the right method. So by performing the right method, what does it mean? Like, everybody performs the culture identification, and AST is the investigation which we all do. But how impact by doing the appropriate right method, that is the automated system, or we can do certain investigations, certain modifications in our culture AST investigations, which will not only improve the quality of the report, but also it will give the report at a faster time. When I tell about the faster time, the most important component, in fact, the last component of the diagnostic stewardship is something which is my favorite component: right time. What does it mean, right time? Right time means the microbiologist should not only perform the right test by the right method, but also they should be able to submit the report to the clinician in quickest time possible. So the most important component, of course, all four are important component, but as far as the microbiology lab is concerned, they should understand. In fact, the clinician also should understand the three variety of or the three categories of turnaround time. So if you try to recollect what we understand the meaning of turnaround time, anybody can tell? What do you mean by the turnaround time? A microbiologist will tell that the turnaround time is the duration between the sample receipt and I sign on the sample report. The moment I sign on the sample report, I'm not bothered, or I do not know what is happening with that. So, so that is the definition of laboratory turnaround time. A laboratory turnaround time has no value unless otherwise it has some impact on the clinical management. Okay. So a laboratory turnaround time has got three components. Like after you receive the sample, you do a culture, followed by you do identification, and you perform the AST. So these three are the component of laboratory AST. What do you mean a ward AST? Ward AST are also called as bed-to-bed turnaround time. Bed-to-bed turnaround time means on both the side of laboratory tract. On both the side of laboratory tract, you add the transport time into factor. You factor the transport time here. So here something called as sample transport time. Here you add something called as report transport time. Sample transport time and report. So now we'll see what is the definition. What turnaround time? The definition is, it is the time gap between the samples are collected and the report have been received by the ward. So don't you think that the laboratory signs on the report, is it equal to report reaching to the clinician? Is it happening in your places? No. If you have a manual dispatch system, then the report goes when you do not know. It may happen that the report will go the next day. It may happen that the report, the laboratory attender will will drop in the dustbin and will go home. You will not know also what is happening with the report. So the report reaching to the ward is at one end, and the samples are collected at the other end. So in other words, it is the laboratory tact, it is the laboratory turnaround time plus the sample transport time in one side and report transport time in the other side. If you add both, then this defines the true meaning of what turnaround time. Now my question to all of you in the house is, the report has been received by the ward. Is it equal the antibiotic action taken by the clinician? No, it doesn't happen so. Especially in a situation where the microbiologist and clinician, they start their job at the same time. 9 o'clock, our JIPA timing starts at 9 a.m. So if the clinician and the laboratory both will start doing their work at 9 a.m., then the microbiologist can dispatch maximum by 11 a.m. by the time the round is over. So once you dispatch the report, after the rounds are over, then it is the next round when the clinician will act on the report, unless you do a critical call alert. So this is again important. So that is why the next turnaround time which has come to the action, that is called as AMSP turnaround time. AMSP turnaround time is nothing but it is a time gap between the culture decision is taken and the laboratory, the antibiotic action has been taken on the laboratory report. So that means what? Here on the both side, you add two time frame. One time frame is called as hangover time. Here I want to ask you one question. Culture decision time and samples are collected. Both the things are same. Dr. Panda, you are a clinician, so you should be able to tell when you decide that you take the culture from a patient, actually the cultures are taken at the same time or there is a gap. There will be a gap always. It may happen that the clinical resident will collect the sample before the next round, anticipating that my consultant will ask me. So that much of delay also may happen. So that gap is called as hangover time. Hangover time has got various meaning. In Pondicherry, it has a very beautiful meaning of hangover time. But as far as diagnostic stewardship is concerned, hangover time is nothing but it is the time gap between cultures, culture decision has been taken and when the cultures are actually collected. So this gap has to be reduced, and this is possible only in the hand of clinicians. The other side is when the antibiotic actions are taken on the laboratory report. So again, the report reaching to the ward, is it same as antibiotic action taken by the clinician? No, the action taken time is always variable. The report receiving to the ward and the clinician act on the report, there are various ways you can reduce that time. So these are the components. So now you discuss. Now let us discuss what are the various modalities, what are the various interventions which we can do by reducing each and every component of the turnaround time. So microbiologists can happily say that the laboratory turnaround time can be decreased by various ways. Already the previous speakers have spoken a lot about this. The most important is automation, which can be introduced, and automation has, I mean, we all have seen, most of us are from INIs, and we have automations in place at some level in our institutions. So we all have seen how automation can bring a change. However, the question is how much you're utilizing your automation. If you have a MALDI-TOUGH in your hospital, but you put the MALDI-TOUGH only daily once in the daytime, that is equal to you're running the biochemical test. You have to have automation running 24/7. As soon as the colonies will grow in the medium, you have to put a MALDI-TOUGH. Then the utilization of automation can be maximized. Similarly, you have multi-tough. The meaning is identification will be available on the same day. You need not wait for the AST report. But as a microbiologist, you wait for the AST report, then ID plus AST both together you authorize on the same day. That means having a multi-tough is equal to not having a multi-tough. You have to authorize the identification on the prior day. So multi-stage reporting, multiple communication between the clinician and the microbiologist is the key behind a successful diagnostic stewardship. Then, of course, direct susceptibility test. It is not a luxury; it is a mandate now. Even CLSI has told clearly in 2021 31st edition of M100 that direct susceptibility test is very much doable, which UCAS keep on telling for last 2 to 3 years now. Now even CLSA also have raised their voice. You have to perform direct susceptibility test. You cannot say that it is a luxury or it is an optional investigation. It is a mandate investigation, because having a susceptibility test available before one day will bring a drastic change in the clinical management. Even if it is resistant to all diffusion by direct susceptibility test, even if the Vitek report will come later, in spite of that, even if it is resistant to all primary antibiotic tested by your direct AST test, that information also to the clinician will be useful, because they can start, they can escalate cholesterol or any other higher antibiotic. So direct susceptibility test again is a mandate. Then the next thing is reporting the frequency. You have to increase the reporting frequency. So this is my favorite intervention, because we have started something called as early reporting. Our blood culture reporting starts much earlier to our department conventional reporting what happens. So we start at 7 o'clock the reporting, and our reporting gets over before the clinicians start their round. So as a result, the report of what we dispatch, that is available to the clinician at the time of the rounds. Twice reporting, evening reporting, all these are small concepts. Holiday reporting again is not a luxury, is a mandate, because how the patients are there in the hospital 24/7, how the clinicians are supposed to work and see the patient 24/7. At the same time, the microbiologist also should 24/7 without an excuse. So these are the various ways you can improve the laboratory turnaround time. What turnaround time? One side you have sample transport time, the other side you have report transport time. How will you minimize? Sample transport time can be minimized by, first thing is increase the manpower, because the manpower is the attenders will be bringing the sample. So increase the manpower, educate them, motivate them. This is stage 1. Stage 2 is, of course, you can, if you have enough infrastructure in place, enough budget in place, then you can introduce pneumatic chute in your hospital, which will be helpful in carrying the transportation of the sample at a no matter of time. It will go very fast. So this is the way you can improve the sample transport time, by increasing the manpower and by introducing pneumatic chute. Okay, then report transport time, how will you improve? Report transport time, the first thing is, if you have a manual system in place, that you have to close down without any fail, and you have to introduce LIS or hospital information system into place. Most of us will have hospital information system, but the thing is, even if you have hospital information system, the report goes only by evening. You will be finishing the reporting by 11 o'clock. Tell your resident, your senior resident, to do the authorization, and they will finish all their other work and they will authorize only by evening. So this is what happens in many of the places. That should not happen. The reporting should happen, the authorization should happen in parallel to your reporting. When you report a sample, at the same time you should do authorization also, so that the communication will go. There is something called as live reporting. Like I told you, the twice reporting is something you can do, like morning reporting, evening reporting. After that, if any other growth occurs, then you can do something called as live live reporting. Live reporting is whenever a growth occurs, whenever the Vitek report is available, the Vitek AST report is available, or even the distribution AST report is available, you have to authorize. You have to authorize. So for that we need to have a 24/7 support of clinical microbiologists. Once it is available, this works very, very good for the clinicians. Okay, how you will improve AMSP turnaround time? Like culture decision, 2 cultures are actually collected. So that is called as hangover time. So how to improve the hangover time? You can improve, or you can reduce, you can decrease the hangover time by educating the residents. So it is it is there in the hands of the clinicians. They have to make sure that their residents draw the sample and they send the sample quickly. Now, action taken time, how will you improve? Action taken time you can improve by something called as bedside visit. Like we do something called as PD AMSP audit, that is a pathogen directed AMSP audit. So after the culture reports are over, we go with the positive culture report to the bedside, and we make sure that within a speculated time frame, the antibiotic action will be taken by the clinician. So we have a bedside discussion between the microbiologists and the clinicians, and that helps in improving the antibiotic action time. I also told you we have improved our reporting time. Early reporting we do, and because the early reporting is happening, as a result, the reports are available for the clinician before they go for bedside round. So these are the various ways. So now now I will tell you the Jipper blood culture division as a prototype, what we have introduced over last 4 to 5 years, the diagnostic stewardship. So I will, before I start the differences what we have introduced, I will tell you the current workflow what we have in JIPMER. The current workflow at the blood culture lab is, once we receive the sample, we have a TAT of 10 minutes to load the bottle. Our entire blood culture lab is under CCTV surveillance, and I have a control over that. So I will be monitoring and seeing that within 10 minutes the bottle has to be loaded to the incubator, that is to the blood culture equipment, and once it flags negative, it should be authorized by auto generated report. So at present in JIPMER blood culture we use a software based reporting we do. The name of the software is IVAR software. It is a in-house software what we have developed for the reporting of blood culture. It is a clinical microbiology reporting software. The name of the software is CMR software, clinical microbiology reporting software. So this software we have developed in-house with the help of a agency called as IVAR, and through this software, so there is a feature in the software what we have introduced, that is auto generated negative report without our signatures. So if in night 2 p.m. Suppose we have received a bottle at 2 a.m. in the night, exactly after 48 hours, 2 a.m. in the night after 2 days, the PDF will be automatically generated and will be authorized into the HIS with a message goes to the clinician having the link of the PDF in the message. So this is what happens if it is a negative sample. So when we call that my negative sample has a turnaround time of 48 hours, you have to ask yourself, is it always you report exactly at the end of 48 hours? Answer is no. Holidays we don't report. We only report the negative bottles as sterile only on the next day. So that is like 48 hours plus the additional time what you take. Whereas by introducing this, our negative report has a turnaround time exactly sharp 48 hours for the prelim negative report and 5 days for the final negative report. What happens if you have a positive blood culture bottle? We have a turnaround time of 2 hours. I have kept a turnaround time of 2 hours. Within 2 hours, the technician posted in the lab will ensure that 3 things have happened. Within 2 hours of a bottle flag positive, they have to perform a gram stain. They have to, based on the gram stain result, they have to perform direct susceptibility tests by diffusion, and they have to subculture on blood agar and Mekong agar. So this should happen within 2 hours, and every day I take a review of the positive flagged blood cultures, that how many have crossed 2 hours. So I keep a thorough vigilant on that, and after that, what we do is, after 8 to 10 hours of the subculture, you will be seeing some minute colony over the plate. Okay. So when you subculture the positively flagged blood culture bottle at 8 to 10 hours, you will see minute colonies, and those minute colonies we subject to MALDI-TOF. So my residents who are posted in blood culture lab, they are not able to see a adult LF or NLF colony, because always we process them at their infant stage. In fact, some at the neonatal stage only we process them, and we will not allow the colony to grow further, and this makes a huge impact because the identification will be ready at 8 to 10 hours. At the same time, DST also will be ready at 8 to 10 hours. So we generate a preliminary report which is roughly around 12 hours from the bottle flags positive. So from the bottle flags positive, around 12 hours down the line, we generate the prelim report, and of course from the same minute colonies what we have put MALDI-TOF, from the same minute colony we also perform colony distribution and colony Vitek, and on the subsequent day, by taking the colony Vitek report, we generate the final report. And when we generate the final report, a lot of advices are will be incorporated, that I will show you in my subsequent slides, like the antibiotic specific advices, therapeutic index related advices, infection control advices. So plenty of advices what will be incorporated. So the software helps in auto generation of the advices. Once the advices will be auto generated, we will be modifying it according to the patient need, and we will be submitting this. So as a result, what we have is our preliminary tag that is from the sample collection till the report generated. Our preliminary TAT is 24 to 48 hours, and for the final report, ours is roughly around 44 to 48 hours. We hardly have any cases which goes beyond 48 hours. So this is a this is the average stat what we have. And when I talk about authorization, like it is a software generated report. So once we authorize, so once I report, at the same time I authorize, at the same time it goes to the clinician. So there is no delay at all. So if I report at 7:35 a.m. in the morning, then same time it will be authorized. Same time the clinician will get a message with the link of the PDF, so he can access the PDF through that link, or even in HIS also he can access the PDF. Okay, so the current workflow what I have shown you here, this is something called as stage 3 of implementation. This is the stage 3 of implementation. So before that, stage 1 and 2 I would like to discuss, because it is not that this kind of reporting we have introduced from so many days. No, it is from 2019 onwards we have a reporting system. 2017 onwards we have started stage 1. So stage 1 we started 2017, where from manual to Excel based register we have moved on. How many of you are still having manual based register? Can you raise hand? Okay, so manual based register has got plenty of loopholes. The most important loophole is you cannot determine your antibiogram. Okay, so I'll be talking about about all the 3 stages. Before that, I'll tell you the importance of automation, which is already been spoken by the previous speakers. I will not overlap their content. I will be confining to the additional advantages. So these are the 2 equipment what we have: Virtuo and Bacterialert. Virtuo has an additional advantage of automatic loading and unloading. So it loads and unloads the bottle automatically without any additional effort. And also it has a blood volume monitoring. It monitors the blood volume also automatically. So these are the two advantages, and because of this equipment our lab flow has been more systematic, because the loading time got decreased. Okay, so as I told you that multi-tub, though it is a revolutionary equipment, again the revolution will actually happen or not, it is purely on the hands of the microbiologists how they are going to run the equipment. Yes, it is true that it gives the result 1 minute per organism. It is absolutely true, but 1 minute per organism only when you load it into the multi-tub. If you have the multi-tub in your department, that doesn't mean that all your results will be that fast. Okay, so there are various way to improvise the turnaround time. Like from the positively flagged blood culture bottle, what we do in Japan is minute colonies we subculture at 8 hours. So this is we thought this is the most easiest, and it is the most least labor intensive method. Other than that, there is a choco spot method where from the positively flagged blood culture bottle you can do a spot inoculation onto the chocolate agar, and you can wait for 3 to 4 hours. You will have a faint growth over the chocolate agar that you can scrap off, and you can put multi-tub. This is called as choco spot method. Blood culture lysis kits are available by the companies, which are very expensive, so we have not explored that, but these are the various methods available by which you can do it. And my urge to all of you is, if you have a multi-tub, then please run multi-tub 24/7. Do not use it like a very delicate darling equipment where you will open the equipment only when the department runs in the daytime. If you have that principle, then use of the multi-tub will be compromised. So please use it as maximum as possible. We run multi-tub in our blood culture lab at least 10 times a day. Whenever a colony comes, we don't allow it to grow further, as I told you earlier. So this makes a lot of difference to the clinician because they will get the identification immediately. So now the question is, automated AST again is a luxury or is a mandate? Any feedback from the house? MIC based detection method is a luxury or is a mandate? Has to be mandate because of there are several drug bug combination where disk diffusion breakpoints are not available. Where disk diffusion breakpoints are totally not available, whether you go for a UCAS or a CLSA based guidelines. So disk diffusion for a long list of drug bug combinations. I will not read this. I will just show you the slide. These are the gram negative drug bug list. These are the gram negative drug bug. I'll tell you one simple question. The residents over who are present here, can you tell me how you are reporting Pseudomonas species other than Pseudomonas aeruginosa? Which breakpoint you are using? Let's say Pseudomonas, some other species. Most of the Pseudomonas other species are contaminant, but suppose you want to report some Pseudomonas as pathogen other than aeruginosa. Which breakpoint you are using? Yes, please remember, you cannot extrapolate aeruginosa breakpoint to the other Pseudomonas species. For other Pseudomonas species in CLSI, the last GNB breakpoint table, which is called as other non-enterobacterial breakpoint table, that table has to be used. And if you look into that table, you will realize that there is no disk diffusion breakpoint at all available for those organisms. So please remember Pseudomonas aeruginosa and any other non-fermenter other than this there is no distribution breakpoint available. So you have to perform a MIC based method. And so also there are long list of gram negative drug bug box. The next slide shows the gram positive drug bug combinations where you cannot have a diffusion breakpoint. The classical example, how you are reporting vancomycin. If you do not have a MIC based method, then you will not be able to report vancomycin for Staphylococcus aureus. So like that, there are a long list of gram positive drug bug bugs for which drug bug combinations for which there is no diffusion breakpoint available. So MIC is not a luxury; it is a mandate. That is the reason why, and the NMC has introduced now that every postgraduate recognized college should have or must have a automated AST instrument. Okay, so now I'll tell you that the software based reporting what we have started in stage 3. So that I have already spoken to you earlier. So now I'll tell you we have gone from stage 1 to stage 2. So this is our initial time frame where we have introduced a change. So the conventional phase was there before 2017 in JIPMER, where we used to use biphagic medium. We have changed that to automated equipment, as I told you earlier. And so this was the first move of what we have done. The second move was only colony DD we were doing earlier. We have now changed to direct DD, colony DD, as well as colony Vitek. Now I'll tell you there are some lab workflow modifications, small workflow modifications we have introduced. In fact, these are the small changes which my senior resident present there over during 2017-18. Dr. Dipasri, he has introduced all these small changes, like for example reviewing of culture smear. Like we had a tendency of, after the reporting over, then the culture smear used to be prepared by the technician, and maybe roughly around 11:30 to 12 o'clock time we used to report we used to see the culture smears. What we have introduced is all these small things like the reviewing of or even the performing lattice agglutination test for Staph aureus from the colony, or even for slide coagulus for Staph aureus, CPS and QH. All this we started performing in parallel to our reporting. It's a very small change, but advantage of that is all these results were reported, where all these results were incorporated on the same day reporting. So this brought a small but a significant change to the clinicians, because for example coagulus negative stuff, or even a candida. How will you report? You have to do a gram stain, then you report the candidate. So if the gram stain report you will see later, and then if you authorize in the evening, then there is a considerable delay. So by introducing this, we have saved a lot of time. Reviewing of plates, what used to happen only during the reporting time in the morning, she has introduced like twice reporting. Then she has introduced 4 times. Like she used to come to the lab very frequently, and she used to review the plates. As a result, our processing happened more frequently. Then we have changed our form also. Our old requisition form was not having any elements, so we have changed our form. We have revised the blood culture requisition. We have introduced the steps of blood culture into the form. So you can see here the steps of blood culture collection were a part of the form, and both the bottles were labeled in the form itself, so that this is a very clear-cut incentive to the clinicians to, I mean, it is an educational form to the clinician that they should read the form and they should read the steps. Blood culture contamination has been a big issue in our hospital because we have a rotational interns who are supposed to collect the sample, and because of their rotational posting, the contamination rate was very high. And because of this kind of form introduction and concomitant training of the clinicians, the contamination rate was slightly reduced, of course, not to a great extent. Last but a very important change we have introduced is we have stopped the manual register in 2017, and the software based register we have started only in 2019. So from 17 to 19, nearly for about 3 years, we have started Excel based register. So Excel based register was a, I say multi-tab now is a revolution. I will tell that in 2017, when we have introduced Excel based register, we felt it was like a boon to the clinicians. I'll tell you the reason why it was like a boon to the clinicians. See, this is not very difficult. Any of you can do it. So each row is for one patient. So we used to so the demographic detail used to be filled by the technician, and followed by the remaining all field we used to fill by ourselves during the reporting time. Okay, so what we used to do is we used to write down the time to positivity. You can see here we used to write down the time to positivity maybe in the before to the organism name, the next column where like time to positivity, then the direct bottle grams report. All that we used to enter by ourselves during the reporting, followed by we used to fill the AST report, and there is to be a, and the last column there is a there is a comment column where we used to write down the comment. So so that is how we started our reporting to the clinicians through Excel based register in 2017. Now we don't do this. 2019 onwards we have stopped doing this. So I'll tell you the advantage of that. Advantage of this is, okay, advantage of this is in the date column, if you apply a date filter, then what will happen is the PDF of today's day report can be generated out. So so immediately after the reporting, we used to generate the PDF of that particular day, having all the sterile report as well as the pathogens all together, and we have created the WhatsApp groups where we used to post immediately. That is how we started in 2017 a concept of reporting to the clinician about the report before they go to their rounds. So it's not that because of software you can do that. You can do everything even without having a software also. So then we used to have our educational session with the clinicians for the to reduce the blood culture contamination, appropriate blood volume, which we have concentrated to the clinicians, because the blood volume makes a lot of difference. So adequate amount of blood volume we have educated the clinicians how you can measure the blood volume. Anybody who is measuring the blood volume in your lab? Measuring the blood volume, of course, if you have a virtual equipment, it will do by itself. Otherwise also all of you can measure even with a Bactec bottle or a Bactiolate bottle. The rule is very simple. The filled bottle weight minus the empty bottle weight will give you the blood volume in grams, and blood volume in grams divided by the blood density, that is 1.09, will give you the blood volume in ml. Okay, so the same Excel what I have shown you, we had a column of blood volume with a formula in place. So moment we used to enter in gram, then the formula used to auto calculate the blood volume, and the actual blood volume was displayed in the next column. So we used to give the clinician how much of blood volume they have submitted to us, and you will not believe that by informing the clinician that you have given this much of blood volume in the culture report itself was a parameter by which our blood volume, the appropriate blood volume rate got increased. Okay, so I have already told you that we started doing early reporting, evening reporting, holiday reporting, then of course authorization, early authorization, and of course, nevertheless, the most important is you should have a 24/7 lab. 24/7 lab, is it a luxury or a mandate? Answer is it is. It is a must for every microbiology laboratory. If you do not have, then speaking about diagnostic stewardship makes no sense, because unless the samples are processed on a live basis, how will you report on a live basis? Okay, so live reporting is possible only when you have a live processing in place. Okay, so multi-stage communication is something we have introduced. Like every stage we used to inform to the clinician. So these are the official WhatsApp group what we have created into way back in 2017. So these groups are functional even now also. So you can see the last WhatsApp post the PDF like that in the group long back in 2017 and 18 days. Nowadays we are not posting the PDF because nowadays the software generated messages directly goes to the clinician. So these are very highly regulated WhatsApp groups, like very close group with the moderation of the consultant of various departments. So this is how we have introduced. So we have done certain studies also to improve our lab stewardship activities. So direct gram stain, I'll tell you that direct bottle gram stain, if you ask me, the most important work of a resident, of a postgraduate student in the blood culture lab is nothing but reviewing the gram stain accurately. And I'll tell you that in 2017, I realized that our gram staining reviewing accuracy was roughly around 60 to 70%. I used to find out why my residents are not able to see. So then we realized that there are various methods to improvise the gram stain from the blood culture broth. We have done this study to look into those methods also. We have introduced few things in the laboratory as a routine, and after that we realize our gram stain accuracy more than 90%. So like effect of blood volume also we have studied, and I have already told you that the normal volume rate or the appropriate volume rate was 35% at the beginning of the study, and that got increased to roughly 60% at the end of the study. Okay, so direct diffusion says 2017 when Dr. Dipasri, senior resident, posted under me. She has put lot of hard work along with all other residents, and we started doing direct distributions, direct distribution tests. That time a big question mark was how much is the accuracy of this, and whether CLSI has not recommended yet whether to continue to do that. So we have published our own results, based upon which we have convinced our department and the clinician two things. First thing is accuracy. If you see here that our accuracy was roughly close to 96%. So if the categorical agreement is 96%, there are only 4% instances where the gram stain, where the direct AST result will not match with the colony AST result. Only those 4% cases when the colony result is to make that as a highlight that these are the antibiotics for which the result has been changed from the preliminary result. So we are communicating to the clinicians at a later stage if there is a change in the report. So by this the department got convinced, and we have started this as a routine from 2017, maybe around May or June onwards till now. Every day we run direct distribution tests. And also we have evaluated direct Vitek. Also you can perform. Of course, it is an expensive element for you. So, but we have evaluated. Okay, there are few other things what you can introduce. Some of them we have introduced in our lab. Lattice agglutination test for MRSA or Staph aureus detection. This will reduce the turnaround time to 24 hours. Coagulase test result will come on the next day. If you put a lattice agglutination test immediately in the like you're reporting side में the technician will put a lattice agglutination test and will tell you it is Staph aureus or not. If it is Staph aureus, MRSA lattice he can put and will tell you it is MRSA or not. This is a very small thing, but will bring a big difference. PCT, role of procalcitonin, CRP, WBC count, all these were already discussed by our previous speakers. They have also about the importance of biofire. So I will not be covering this because these are already been covered by the previous speaker. One thing I can add to the biofire is there is a blood culture identification 2 panel which can detect the carbapenem at least 10 different AMR gene within 1 hour of the flagged positive of the blood culture bottle. So when the blood culture bottle flags positive within 1 hour, it can detect at least 10 different AMR genes. So this, but only thing is it is very expensive. This we have not introduced in our lab, but I have heard about this from the ID physicians that this helps a lot in their clinical management. So also expert Eucarba R test, it also can detect various carbapenemase genes within a turnaround time of 2 hours directly from the blood culture broth. So these are the various things what are available. So stage 3, as I told you, in the stage 3 we have introduced the software. So this is the software what we use. It is a IVAR Jipmer software. So each row represent a patient row. So this software has the capability of, the name of the software is CMR software, that is the clinical microbiology reporting software. This software has a property of generating the report by itself. So it captures the data from the blood culture equipment, from the Vitek, from Malditop, all the 3 data it captures. All the AST will be reinterpreted by the breakpoints which we have fed into the software. Like both the CLSA and UCAS breakpoint are been fed into the software. So the software has a capability to reinterpret the results and generates the advices. It also adds on the Gram-Stain result, the time to positivity, all these informations it integrates and it generates the report. So I can show you this is one of our report of auto generate. So when we generate a report, the report looks like this. It goes as an SMS to the clinician. So this is a message to the clinician with the link at the bottom. So when they press the link, the PDF will be generated. Otherwise, also the same link will be available in the information system. So this is it's an extensive report. It has got some 4 to 5 pages per report. It develops. So the first page is about the demographic detail. Then the initial information. You can see here that we also give the various, like we give the blood volume to the patient. So we mentioned the blood volume here. So once the blood volume is been mentioned here, with the blood volume we write a comment also that this blood sample was having inadequate volume or it was having adequate volume. So that comment also goes along with that. Then comes the time to positivity. So 8.8 hours, for example, in this case, the time to positivity. Then comes the direct Gram-Stain report, then the organism report. Then the second page, you can see the second page shows the direct susceptibility test report, DST. So it is a preliminary report what I am showing you, direct susceptibility report along with antibiotic advice, infection control advice, and also incomplete form filling advices. If the clinicians will not fill the form appropriately, those comments also will come in the form, in the report. Okay, so next comes the final report. So the next comes the final report where we give the Vitek report Vitek AST report along with the concept of therapeutic index. The last column you can see here, the last column, you will be able to see that we are giving the therapeutic index information to the clinician. So the therapeutic index, I will be explaining about the therapeutic index in the next slide. So here I'll just tell you that two things we tell to the clinicians: therapeutic index as well as the MIC guiding table. So both this goes to the clinicians. MIC guiding table has been derived from the therapeutic index in the form of the dilution chart of Vitek. So along with that, the antibiotic advice. So based upon, so like for example, in this case, we have the best therapeutic index was available for gentamicin. Therefore, we have given here gentamicin as the drug of choice. So along with that, we also give the antibiotic specific advices, infection control advice, so on. Okay, so then the last page I have already shown you earlier, incomplete form filling page, where if the clinicians have not filled the form any particular component, either the antibiotics are started before collection of culture, all those comments will be appearing at the last page of the form. So so what do you mean by the therapeutic index? You can see that most of us give the Vitek report like this to the clinician. So you can see here there are so many antibiotics which are susceptible. So if you have a list of antibiotics which are tested susceptible, the clinician will get confused which antibiotic to give to the patient. So the clinician will think that which is having the lower MIC may be having a better efficacy to the patient. So here we have to educate the clinician that it is not the lower MIC, but the lower MIC with respect to the susceptibility breakpoint. That gives the better efficacy. So that concept can be determined by a concept called as therapeutic index. Therapeutic index, it is like test MIC therapeutic index means it is the test MIC by the susceptibility breakpoint. So the concept of therapeutic index can be better explained if you plot a MIC guiding table. This table is called as MIC guiding table. So in this guiding table, what you can see here is in each x-axis is the dilutions of antibiotic which the Vitek will test, and what is your MIC for this particular isolate. That MIC has been circled as black. So can you tell, anybody in the house, can you tell based upon the formula what I have written here, what is the therapeutic index of cefepime? Cefepime, the test MIC, the formula here is susceptibility breakpoint by test MIC. Susceptibility breakpoint by test MIC. So here your breakpoint for cefepime is 2 divided by the test MIC for cefepime is 1. So 2 by 1 equal to 2. So cefepime has a therapeutic index of 2 here. Anybody can tell what is the therapeutic index of piptas? Piptas. Anybody can tell what is the therapeutic index of piptas here, please? Yes, piptas 16 is the susceptible breakpoint. So 16 by 4 equal to 4 here. So you can see by seeing this, the clinician, if you see only the raw MIC values, you will get confused that cefepime is having a lower MIC, cefepime is having a lower MIC than piptas. So you may confuse that cefepime ka MIC is 1, piptas ka MIC is 4, so cefepime may be more effective. Actually, it is not the case because cefepime ka susceptibility breakpoint is only 2. So compared to 2, it is only 1 dilution less. Whereas for piptas, the susceptibility breakpoint is 16. So compared to 16, it is 2 dilution less. So piptas, the therapeutic index is supposed to be higher than that of cefepime in this case. So this concept is called as therapeutic index. So what we do here is, you can see here, we give this kind of report to the clinician. We give 2 tables. First table is we classify the antibiotics into first line, second line, and a restricted group of antibiotic. This classification is based upon the mutual understanding of Department of Microbiology with the clinicians. Then we write the MIC values, result, then the susceptible breakpoint, then the therapeutic index. And to make them understand more of therapeutic index, we also give the MIC guiding table at the bottom, so that will give them more clarity how to use the concept of therapeutic index when they treat the patients. One thing what I want to tell you is, therapeutic index concept can be applied only after the cascade reporting concept is applied, because even if the therapeutic index of restricted antibiotics may be very high, but if you have a first line antibiotic available for treatment, then that has to be the treatment of choice. So therapeutic index concept will come only after the cascade reporting to the picture. I have given you here the entire list of result, because to make you understand the concept better. But the same result, if I will be authorizing for the patient in my institute, I would like to suppress the restricted results, because the second line antibiotics are available for the patient. So this is called as the concept of cascade reporting. Okay. Okay. Now I'll tell you the 2-stage reporting model what we follow. 2-stage reporting model means we usually incorporate plenty of comments to the culture report. So all these comments incorporating is possible only when we divide the reporting pattern scheme. So the same model is been followed in the Western culture. If you look into the UK culture or the US culture, they have a 2-stage reporting system where they have a technical team and they have a clinical microbiologist team. They operate separately. We have adopted the same model. We have adopted the same model in an Indian Western way. So this is our reporting lab in blood culture lab. So this whole the whole team can be divided into 2 groups. Team 1 is like has been comprised of a senior technician, then the SRF of a project technician, junior resident. If I have 2 junior residents, then 1 junior resident will go there. And if I have some MSc or BSc MLT for that particular month, then they also will be added to the group. So this is called as team 1. So the responsibility of T1 is they will prepare the ID AST results available. And the zone diameters, so we don't see the plate and we interpret the zone diameter by our mind. This concept is totally not there in our lab. The interpretation of zone diameter is the job of the software. Our role is to enter the zone diameter into the software, then press on the interpretation, and the software will verify. The software will interpret the zone diameter as SIR based upon the breakpoint entered into the software. So this is the role of team 1. Team 2 is been comprised by the consultant, junior resident. If I have another junior resident, then he or she will be added here. Usually I have 1 junior resident. In that case, that JR will go to team 1. And of course the senior resident and me, we do the clinical microbiology reporting part, where we incorporate plenty of he comments to the report. So what are the various classes of comment and how the comments will be useful to the clinicians? This is altogether a separate session. I will not take into the detail. I will only brief you the various classes of comments what I will what we report in the software. So all these comments are been integrated into the software. So whenever we report an organism, all these comments will be auto-generated by software. Our role is to verify the comment, edit the comment, and modify the comment. So the first class of comment is like whether it is a sterile report or it is a contaminated report or it is a pathogen or it is uncertainty. So for each of the report category, the respective comment will be added by the software into the report. Second category of comment is in progress report. How many of you have a practice of informing the clinician what has been awaited? Is it important or not? You perform the AST. It is registered to all first line. You are going to test the colistin. If you don't report to the clinician that the colistin report is awaited, how the clinician will know that I will get a report tomorrow? So this classification of comment is called as comment for in progress report, where what is been awaited, the respective comments are added to the report. Third category is comments if the parameters which the clinicians are supposed to fill, if they are missing in the culture equation form, then also we have, so these are the various parameters what they are supposed to fill. If they are missing in the culture equation form, then the respective comment will be added and that will be displayed to the clinician, and you will be surprised to know that by seeing this kind of comment every time, the compliance to improve the particular item has been enhanced by our clinicians. Then the third is comments related to various specimen collection. So for example, you should have the clinician should have a concept of culture of culture. So the meaning is the antibiotics should be started only after the cultures are collected. So if they start later, then the respective advice will come. Blood volume comment, I have already shown you less than 8 ml, 8 to 10 ml, more than 10 ml. The respective comments are added to the screen. The whole of the comments we have published as a review article. You can go through this later also. I am just going through this so that I will just make you familiarize with the various classes of comment what we give to the clinicians. Then the source of blood culture also, if it is not appropriate, if they don't send in pair, or if the central line is there in place and they have given only the central line sample, they have not given the peripheral line sample. So then the respective comments go to the clinician. Then comes to the expansion of SIR. We all think that SIR is what is very, very easy. Oh, why to expand it? But if you ask to your resident in your lab, what is the meaning of I? What is the meaning of I? If you ask anybody in the lab, either to our or to the clinicians, I'm sure that 9 out of 10 will fumble. The reason is we have to explain them. So please remember SIR interpretations. I mean, the expansion of that should be a part of the footnote of your AST table. Don't take it to granted that your clinician, especially I, the meaning of I, they will not know if you don't express that in the footnote. Similarly, if it is susceptible to more than one antibiotic, I told you that we usually give therapeutic index. If it is resistant to all, then we write a rule called as 90-60 rule, and we explain to the clinician that still you can choose among the resistant antibiotics, whichever is suitable to the patient, because the 90-60 rule says that there is a 60% of chance still the antibiotic may work in vivo if it is tested resistant. Okay, then the comments are related to site-specific culture, like time to positivity. How many of you report time to positivity of your blood culture bottle flagged to the patient, and how does it make a difference? I'll tell you that time TTP, or the time to positivity, is very, very important, because low time to positivity, worse is the outcome, or better is the outcome. Worse is the outcome. The lower the time to positivity, worse is the outcome. Like the gram negative, the cutoff is less than equal to 6 to 7 hours, and gram positive, the cutoff is less than equal to 12 hours. So most of the researches which have been carried out on this, they have shown that this is a cutoff below which you have to inform the clinician that the patient may be sick, because the organism load is high. Therefore, the time to detect by the blood culture machine has been reduced. So this comment always a part of our report. Then if it is a CR-BSI case, then we have a long list of comment what we add to the patient report. So this comment goes along with the patient report if it is a CR-BSI case. Infection control advices, as we all have discussed in the morning, all this goes to the report always. And then the various antibiotic related advices, if it is MSSA, MRSA, then the respective comment goes. If it is cefepime for, then the comment on SDD goes, that is a susceptible dose dependent comment goes. If it is VRE, then the infection control advice goes. Repeat culture is mandate for, there are few CLSI recommended drug bug combinations for which repeat culture is a mandate. So that also goes to the form. Renal adjustment comment goes for renally compromised antimicrobials. High level gentamicin, we have a specific list of comments. So if the respective combination of result comes, then the respective comment, the software will auto generate. All these comments, the software has a property of auto generating the comments. CLSI has given in 2020 itself a long list of 4 comments if you have a colicin to be reported. So this is a list of colicin advices what is been incorporated to the software. Okay, predicted susceptibility. You know the concept of predicted susceptibility. For example, you are testing for tetracycline, but based upon the tetracycline result, you can extrapolate to doxycycline if it is susceptible. Ceftriaxone result can be extrapolated for cefotaxime enterobacterial family. How the clinicians will know about this? So unless this kind of comments form a base of your form of your report, your clinicians will not be aware about extrapolation of antibiotic results. So this kind of extrapolation of antibiotic results are very, very important. Of course, the last but the most important part of the comment is intrinsic resistant comment. How many antibiotics Pseudomonas aeruginosa is intrinsically resistant to? You will tell that ceftriaxone. Absolutely agreed. But you know that Pseudomonas aeruginosa is resistant to 41 different type of antibiotics. And it is humanly not possible, neither for the clinicians, not by the microbiologists, not by the pharmacologists also, the list of antibiotics. So, but it may be possible that the clinicians may be giving those antibiotics to the patient. You can't rule out that exception. Therefore, IR comment or intrinsic resistant comment has to be a mandate in your form. You have to have a table, a small table at the end. You have to add the list of antibiotics to which the organism is intrinsically resistant. Okay, so these are the various classes what we report to the patient, and once the PDF is generated, as I told you, it goes as a automated SMS to the clinician. But at the same time, the microbiology resident, the diagnostic stewardship team, they go to the bedside and we do something called as pathogen directed AMSP round. Pathogen directed AMSP round means the positive blood culture reports. The microbiology residents, they go and they discuss with the clinician on case to case basis. And one of my PDF candidate is doing a dissertation also on this topic. So this particular intervention we are doing from 2017 onwards. From stage 1 of implementation onwards, we are doing this intervention, and we are finding it excellent. The clinicians, because we keep on banging them, we keep on advising them, in spite they would have not seen the report in their mobile, our intervention will act as a boost to them to intervene immediately, especially melidiosis cases, Burkholderia, Pseudomalai cases. The patient die in no matter of time. Pneumococcus in babies, they die in no matter of time. So by the time the clinician will change the antibiotic, the complications would have been developed. So therefore, this kind of pathogen directed AMSP round helps a lot to the clinician. We have 3 modes of communication to the clinician. Communication 1 is over the phone. It is called as the critical report. We inform them over the phone. Then second stage is verbal communication at bedside. At the bedside, we discuss with them, and we mutually educate them, and we educate ourselves also. Many a time after going to the bedside, we realize that the steps what the clinicians would have taken has a logic inside. So unless you discuss with them, you will be thinking that they are wrong, they will be thinking that you are wrong, and the mutual consensus will never arrive at. Stage 3 is we give a written communication to the clinicians through a form called as pathogen directed AMSP form. So this is the form what we give to the clinicians. I will just show you the enlarged version of the form with the type of antibiotic advices. So this form comprises of the various classes of antibiotic advices. One of the antibiotic advice will be given to each and every case. So if empirical antibiotic is not going on, then the advice is start. If empirically correct, then the advice is continue the current antibiotic. If empirically incorrect, then you have either change of spectrum or change within spectrum. Change of spectrum means what? Gram negative going on, you change to gram positive. Or antibacterial is going on, you change to antifungal spectrum. This is called as change of spectrum. Change within spectrum means gram negative only is going on, and you have developed a gram negative organism in your culture. However, based upon the antibiotic lines, that the first line, second line, and the restricted line, either you go upwards or you go downwards. Accordingly, you have escalation advices and de-escalation advices. Apart from that, change of antibiotic is another class of advice. Change of antibiotic is again, it can happen within the line, or it can happen across the line, but it doesn't fit into escalation or de-escalation classification. There will be plenty of examples you will encounter. Those cases will not fit into escalation or de-escalation. Those we have grouped into change of antibiotic as a advice, and that can happen across the line. So these are the various classes of antibiotic advices what we give through the pathogen directed AMSP round. So this is all about. So I have briefed you from the starting of the the importance of the turnaround time, and every stage of turnaround time. There are various interventions which we can make, and majority of interventions as a microbiologist we have to do for diagnostic stewardship, whereas some of the interventions the clinical team also can do to improve the turnaround time. So in the month of September last week, we had 5th advanced national workshop in hospital infection control. God's grace, the COVID was going on at that point of time, a little higher number of cases than what we have at present in Pondicherry. 152 plus some day specific participants. Altogether, around 175 participants have been enrolled for this event. And this particular picture shows you that they have, it was 12 hours per day into 5 days. So 60 hours they spent inside the auditorium without removing the mask except for 10 minutes during the lunchtime. So this was, would have witnessed the event also. Dr. Sumit, Dr. Panda, all were there. So this is what about, and I would also like to acknowledge about the session to the team without whom the implementation of diagnostic stewardship in Japan would have been impossible. My ex-HOD, Dr. Sujata, she was instrumental in supporting me to introduce, because we have a load of, I'll tell you, we have a load of around 100 to 120 bottles per day. So 120 bottles from a BHI bottle to pan automation. I mean, Eubacteria alert was a budget of nearly 1 crore. So it was possible because of admin support and my ex-HOD support, Dr. Sujata, and of course, Dr. Channa is the current HOD who is also instrumental in supporting diagnostic stewardship. My junior residents, a few of them are present here in the house. I am extremely thankful to you for the support, and more importantly, all my 3 senior residents. I'll tell you that without those 3 senior residents, whatever is been developed in Jipper HIC or Jipper blood culture lab would have been. So the first senior resident is Dr. Dipashree. She was there with me from 2016 to 19. At present, she is an assistant professor in JSS Medical College in Mysore. And the second senior resident was Dr. Harita. She was ex-PDF. I mean, we have started a course called as PDF in hospital infection control. So she was the first candidate. And before Harita, Dr. Dipashree was there with me. And in fact, me and Dr. Dipashree, we started everything from scratch. Like from the, we have seen both phases of our lab. We have seen from the phase of BHI to the phase of Excel to the phase of software. So she was like a pillar behind development of all this. And Dr. Harita took over from her, and she was there for 1 year, and she has supported a lot. And of course, now I have an outstanding. I can say I have another outstanding senior resident, Dr. Ketan, who is there with me from 2020 onwards, and he is extremely sharp and highly dedicated. So I dedicate my session to my team, and with my team I have started a new project that is essentials of antimicrobial stewardship. So I would like to announce the launch of this project with the permission of AIMS Patna organizers. So this is essentials of antimicrobial stewardship. We are expecting this to come. I mean, to be released in 2022. So these are the various outline of the book, and that's all is the presentation. I have taken 1 hour, or is more than 1 hour. Okay, so any queries or any further discussion we can have? Yes, Sagar. Dr. Sagar was my senior in MKCG Medical College, MBBS senior. Yeah, it's very painful. Give the mic.
So he is talking about 5 hours. The whole point of AMSP is leadership. I do not know how many of you have read about the GAP AMR white paper book of WHO and the NAP AMR of Government of India. There is only one difference. One difference between GAP AMR and NAP AMR. Anybody can tell it. Faculties. There are 5 strategic priorities defined by WHO, and Government of India added only 1 to it. That is the 6th strategic priority for National Action Plan on AMR. That is the role of leadership. So we have to be leader in this particular field and try to improve, encourage as much as possible in whatever way you are doing it. I am really glad to know about the JIPMA team, starting from PGI team and AIMS Delhi team. With the normal workflow, normal duty hours, not possible. Forget about it. It has to be extra, added, additional. Then only the whole concept of AMSP will be fruitful. Thank you, Dr. Sastry.
So I think we have few questions online, sir. So
Yeah.
just Dr. Pooja will just go on with that question.
So this question is by Dr. Preeti Bala. She asks, if we subject early growth of few organisms like Candida, etc., we don't usually get the report. Especially Vitec people recommend you doing ID and IST only after proper colony maturation. Kindly share your experience. Thank you.
Can you summarize that again? Candida, IDAST?
So she's asking that if we subject early growth of few organisms like Candida and other, we don't usually get the report. Especially Vitec people recommend doing ID and IST only after proper colony maturation. So she's asking about early growth.
Doesn't matter at all. Candida also can be identified by multidrug at 8 hours of subculture.
So
That doesn't matter. See, the preliminary report, you have always an opportunity to send a second report to the clinician. So if any mismatch happens, you can call them, you can inform them. See, the component of having a wrong report at an early stage is only 4 to 5%. But the component of giving a correct report accurately is more than 90%. And that will happen with a reduction of turnaround time of 24 hours. So difference to the clinicians.
So next question is by Dr. Sangeeta Gupta. She asks, how can we calculate actual therapeutic index by Vitec? Actual therapeutic index by Vitec.
Actual therapeutic index. There is only one therapeutic index. What is actual therapeutic index? Therapeutic index is susceptible breakpoint by your MIC. So if the susceptible breakpoint is 4 and your test MIC is 2, then it is 4 divided by 2 is 2. So it is like that. See, the therapeutic index concept, MIC guiding table concept, I would like to add here. You can do it without having a software also. Like the MIC guiding tables, without circles, the MIC guiding tables SS is available by the bioMiro team, or you may draw it by yourself also in a tabular form, or you can ask me. I can share you our PDFs also. So those tables you can take printouts, and you can circle the MICs of your particular isolate. You can write down the therapeutic index by self-calculating, and at the bottom you can write down what is your drug of choice. So that printout can be added to the patient case, explaining to the clinician. So this can happen even without having a software also. I think Dr. Sumit, you are doing that, right?
So one more question by Dr. NP Singh. He says, what is your experience with other catalase negative streptococci other than GPA and enterococci?
Other than group
Other than GPA and enterococcus by Marley.
Group A streptococcus, enterococcus. Other than that, group B streptococcus also can be detected, and it can cause bacteremia also. And streptococcus viridans is important in blood culture only in infective endocarditis. Otherwise, it is most of the time it is a contaminant. Nutritionally deficient streptococci are another group of streptococci which once in a while can be detected, and these automated systems, they have the property of growing that organism. So you may get that also. That has specific treatment modalities, so you need to inform the clinicians. That is why the importance of putting a staphylococcus aureus strict line in your blood agar plate, because that will pick up the nutritionally deficient streptococci. So these are the various other streptococci which can.
Thank you so much, sir.
Thank you. Yes, Sumit. Give the mic. So another diagnostic steward, Dr. Sumit, he will have a session tomorrow.
Both of us, we are actually processing pediatric colonies, right? Colonies growth of 6 to 8
neonatal
hours.
colonies.
Right. I call them pediatric colonies. I am from a pediatric institute. The thing is that in your personal experience, have you found, it's a similar question, have you found any difference between the susceptibility profile of a colony at 6 to 8 hours versus colony at 16 to 18 hours? Because when I was following this practice, some of the senior people used to say that you're over-reporting, you are being over-enthusiastic in reporting. There's going to be difference in both of them. What you're processing at 6 to 8 hours.
Colonies, you're telling?
Yes, from the colonies.
We have not done any studies like that. Maybe if you're expecting that, then maybe a difference.
No, I'm not expecting this. Like senior people, they say that no, it's written in the books that you
We
pick
can
up the
do-
colony only after 16 to 18 hours. Before that, you don't pick up the colonies. Probably because the resistance genes don't get expressed at 6 to 8 hours. They get expressed maybe at 6. So it is possible that you might be getting more susceptible AST report with 6 to 8 hours growth as compared to 16 to 18 hours growth.
So this will form my objective of my next study.
So I'll be the co-investigator in that.
Thank you, sir, for such a wonderful interactive session. Now I would like to request Dr. Vinod Kumar Pati, sir, to present a memento to Dr. Apurba Shankar Sastry, sir, as a token of our gratitude.
So, Dr. Vinod was a participant in 2019 workshop, and he is the diagnostic steward of Patna.
So with this, we come to an end for today's session. I would like to thank all the speakers for their enlightening and informative talks. We'll break for tea now and end today's session. Please join us for gala dinner at 7 p.m. at the auditorium. Thank you.